Good evening, everyone, and good morning to Dr. Jerry, if he's joining from the US. Welcome to our fireside chat for this evening or morning, depending on where you're joining from. This is going to be our 207th webinar series, and the topic for this evening is how to construct an AV fistula. And we are going to be taken through questions and clarifications that the team has, so that Dr. Jerry is going to address them in full. Before we proceed, my name is Dr. Yuri Okech. I'll be the moderator. Another co-moderator will be Rahul, who's joining from Zambia. So we'll just be moderating the session and helping out in the background. So before we start, I would want to introduce Dr. Jerry. So Dr. Jerry Svoboda is a senior vascular surgeon based in Rochester, New York, affiliated with Unity Vascular Surgery. He graduated from Heinemann University School of Medicine in 1977 and completed his surgical residency at Inglewood Hospital and Medical Center. He is board certified in both vascular surgery and general surgery. With more than 40 years of clinical experience, Dr. Jerry has also served in the US Army, Medical Corps Reserve, with deployments in Iraq and Afghanistan. He is actively involved in global medical missions, providing surgical and medical support in countries such as Ecuador, Peru, and the Dominican Republic. He has also participated in community-oriented volunteer medical programs with his family. Dr. Svoboda academic contributions include publications in the field of vascular and thrombolytic therapy, including work on thrombolysis for acute stroke. He is a fellow of the American College of Surgeons. And just to mention, Dr. Jerry has participated in multiple camps. I think in Ethiopia, he helped us quite a bit in Kenya to train surgeons. I think he has done a lot of capacity building and upskilling of surgeons, and that has ensured continuity in creating AV fistulas for patients in need of them. I think of most recent, he conducted a camp in Tanzania last month, and we had quite a number of accesses created. So we continue to learn from him as a pioneer in the field, and also as a great teacher in the surgical field. So over to you, Dr. Jerry, and I'll let Rahul on the other side to just share the slides. Thank you.
Thank you. I hope you can hear me. Thank you, Dr. Okech. I want to make one correction. I'm retired now for 5 years from clinical practice, but still doing missionary work and overseas work. And I am no longer certified in general surgery. I let that board expire as of last December, but I recently renewed my boards in vascular surgery. Okay, now you see the purpose of the AV fistula camp, and I know that your primary clinical teacher has not yet arrived, or maybe not on the call. Perhaps he'll join us. It's a pleasure to be here today. The idea is that we want to show people through this slideshow and also your clinical experience following in the camp how to make an AV fistula, because most patients on dialysis in East Africa still to this day are using a catheter. And we now know that catheter patients don't live as long as fistula patients, and they have fewer, fistula patients have fewer hospitalization days every year. So there's plenty of reasons to make AV fistulas for people if they have adequate anatomic material. Because we have people on the call that may not know some basic things, we'll start at the basic level. An AV fistula is a connection surgically made between an artery and a vein. The idea is to make the vein get larger, to divert a rapid blood flow into a vein where a nurse can reach it with a needle. We call that an AV fistula. If you involve an artificial prosthetic piece of tubular material for the vascular connection, then it's called an AV graft. So on the top picture here, you see an AV fistula that is mature, which means the vein has grown larger. You see the scar by the wrist of the patient. That's where the connection has been made. And now this fistula is perhaps a year old, and you see multiple puncture marks along it and the enlarged vein. In the picture below, you see one type of anatomic configuration, how a tubular prosthetic can be used to connect an artery and vein. There are many variations on this, but the difference here is between an AV fistula on top and an AV graft below. These are the size needles that are used to access either a graft or a fistula, and we'll be talking primarily about AV fistulas because graft material is expensive. It requires a lot of maintenance and is not readily available in East Africa. 18 gauge needles are used very uncommonly. Usually the needles are larger, as we see here, from 14 through 17 gauge along the row. A 19 gauge needle would be 1 millimeter in diameter. A 14 gauge needle on the far left would be 2 millimeters diameter. Next, for terminology, if you hear an AV malformation, that's a naturally occurring pathology, congenital pathology between an artery and a vein. So we're not going to be talking about that. But the term AV fistula can be applied correctly to a pathological condition in which an artery and a vein become connected, usually through penetrating trauma, often a stab wound or sometimes something iatrogenic done during an access procedure. That's pretty rare though. And here you see dialysis patients with they're connected to their machines, and you see the person in front of us has a large vein developed on her arm. So cosmetics become a concern for the patient. Initially, after the AV fistula is made, everybody wants the vein to grow. And then it reaches a point and everybody wishes it would stop growing. But a successful fistula allows a nurse to hit the fistula successfully time after time after time. Next, these pictures show examples of AV fistulas. And in the right lower picture, you might wonder, is this an AV fistula or an AV graft? It's so nice and straight, whereas the other ones are convoluted because the vein takes its twists and turns. To distinguish, if you see a patient in front of you with an access on their arm and you're trying to determine, did somebody put a graft into this patient? The patient will often not know. They might, but they might not. Look for the scars. If there are two scars, one at each end, it's most likely a graft. If it's nice and straight or a nice smooth curve, it's not most likely a graft. But you won't see many of those in East Africa. Now, the ideal AV fistula is done as an outpatient, but we have found during the 3 prior AV fistula camps that we have held that keeping the patients overnight in East Africa, at least at this time, is a good idea. Our recent AV fistula camp was in Tanzania, in Dar es Salaam, and it was very helpful. We don't want these patients riding home on a motorcycle 20 minutes after their surgery is done. So keeping them overnight is probably the safest thing, but that's at your discretion. The ideal fistula is ready to use in less than 2 months. That doesn't often happen, but it can happen. I tell people when I'm explaining this to them that the fistula is ready to use in between 6 weeks and 6 months. The ideal fistula has a flow rate over 350 mLs of blood. That means it can deliver to the dialysis machine that rate with uninterrupted patency. That means that the fistula hasn't blocked, and every fistula has to prove itself by being patent every day of its lifetime. Ideally, it's cosmetically acceptable to the patient and that it lets enough blood go to the parts where God wants the blood to go, like the fingers or the foot. The nurses can cannulate the fistula easily. These are all ideals. Historically, the AV fistula was preceded by a Scribner shunt, and both our host LloydVincent and I both have experience with this in our younger days. It was developed in 1960 at the University of Washington, and it was a plastic tube, one into the artery, one into the vein, connected together. So it was really called a shunt rather than a fistula because it involved a prosthetic piece. And Lloyd and I both know that historically, some of these were then converted to AV fistulas. On the top picture, you see the incision, which was used to access the radial artery and the cephalic vein. Well, to convert this to an AV fistula, the incision was reopened, the cannulas were removed, and the artery and the vein were connected together. We'll talk a little bit more about this later. The first dialysis, by the way, was done in the Netherlands in 1945. Next, at the same place, the University of Washington, Dr. Quinton developed the dialysis catheter, which was initially, if you look at the very top, which was initially a single lumen catheter, and the machines were set up to use that. But quickly, it developed into a 2-lumen device, a side-by-side catheter, and eventually was developed into a unit that could be implanted. And ideally, these days, if patients have to continue with a catheter, it's an implanted type rather than an acutely inserted type. The difference being a short tunnel between the skin exit site and the entry into the vasculature. Continuing with our little history lesson here, Doctors Brescia and Semino, the two internists on the left, nephrologists, they developed the idea of the AV fistula, and their surgeon, Dr. Apple, on the right, made 14 AV fistulas for them, and they published the series in 1966 from Bronx, New York. Here you see different ways of connecting the AV fistula together, the vein and the artery. Dr. Apple made the Brescia-Semino fistula by a side-to-side connection. These days, almost all AV fistulas are constructed by an end-to-side, end of vein to side of artery technique. The conversion of the old Scribner shunts was usually done by an end-to-end technique, as you see in the right lower corner. These are historical techniques. Today, only picture B is in common use. This is an example of the difference between an end-to-end vascular anastomosis and an end-to-side vascular anastomosis, as pictured on mock arteries sewn by the general surgery residents in Latane, Kenya. The nice thing about vascular surgery doing AV fistulas, and any surgeon can be taught how to do it. A nephrologist can be taught how to do it. Anybody with reasonable intelligence and a reasonable set of hands can do it. The surgical exposure is usually superficial. It usually involves one anastomosis, whereas a graft would require 2. It usually does not require general anesthesia, and AV fistula surgeons are most successful if they have obsessive compulsive disease. I say that in jest, but not in jest. Regarding anesthesia, at our last AV fistula camp in Tanzania, no patient received any sedation or general anesthesia. They were all done with straight local. In our 2 prior camps in Kenya, we often had a nurse anesthetist giving intravenous sedation, but this isn't really necessary. Most African patients, it seems, are more stoic than North American patients, and they tolerated it very nicely. The goal of the AV fistula camp, and I can only speak for the camps that I've run, but you have a wonderful teacher coming up who's en route. But all I can say is if you learn how to do an end-to-side wrist fistula and an end-to-side antecubital fistula, you'll be in pretty good shape. The idea of AV graft use will be minimized in East Africa, as we talked about. We're going to look at some of the instruments. Many of these instruments are familiar to many of you, but strange to some of you. The forceps, you see on the left slide, smooth Adson forceps with teeth on the right blue picture and without teeth or smooth on the left blue picture. And then you see jeweler's forceps to do the anastomosis in the right white picture. We also use certain very fine eye instruments, including bona occulta forceps in this regard. The needle holder to do the actual sewing together of the artery and vein is a Castro Viejo needle holder. I tend to like a locking short instrument like this. Some of you have experience with these instruments, some of you don't. So that'll be one of the things you'll be learning in the camp. Some people like a longer one, some people like a shorter one, finer jaws, broader jaws. It's originally an eye instrument. Castro Viejo was a corneal transplant surgeon. Various retractors you see. The one on the bottom is a Renal retractor. It's a plastic surgery retractor. Many of you are familiar with the Sen retractor on top, and the little clickety-clack retractor called a Heiss or Holzheimer self-retaining retractor does find use in AV fistula surgery. I don't know exactly what type of instruments you'll have there. At the previous camps, I often brought the instruments, but I won't be there with you, I'm afraid to say. But it's helpful to have a set of dilators. These aren't absolutely necessary, but they are helpful, and they come in diameter sizes between 1 and 5 millimeters in diameter in 0.5 millimeter steps. At any time, if anybody has a question, just interrupt me. That's perfectly fine. Just speak up and we can handle any question. Vascular clamps are used during AV fistula surgery. Once again, these things are not absolutely necessary, but very helpful. These are two types of bulldog clamps. The little one on top is used to control back bleeding from the vein. So it's very delicate and a very light touch on the jaws. It doesn't damage a delicate vein. The stronger one below has heavier jaws, stronger spring tension, and is used to control the artery. Typically, this one is used to control the brachial artery. These 4 metal tips are all pretty much the same. We call them an olive tip, or they can be called a heparin needle, and they're often used on a 5 or 10 cc syringe with saline or heparinized saline to make sure that the vein is open. The metal tip is 3 millimeters in diameter. It's the same as a 3 millimeter diameter dilator. We'll come back to that point in a minute. The most common used heparin flush solution is 1,000 units in 100 ml. You might want to write that down, especially if you're attending the camp. That means 10,000 units of heparin per liter, or 5,000 units of heparin per 500 ml of saline. Depending on how your heparin is coming, you can adjust this accordingly. But it's very good to have heparinized saline available on the table where you're doing your AV fistula. Magnification is used by most people making AV fistulas. On the left is the inexpensive choice, which I used my entire career, called an OptiVisor. And these are readily available either from sources in the States or China, and they're inexpensive. Some of you may have magnification loops. One of our students in Tanzania was a plastic surgeon, and he came to the camp with his own loops. But low power magnification is helpful. 1.5, not over 2.5. Here's a question maybe. Thank
A
you.
participant by the name Vera is asking practically, what's the cutoff age for AVF creation?
The cutoff age of a patient, there's no practical cutoff age. You can make an AV fistula for a 90-year-old. Now, it is true that many people might say, well, he's 90 years old, let him go on with his catheter. And I wouldn't argue with that. But it's a simple operation for most people. In the States, wrist fistula can take 1 hour to do. When you're getting started, it's probably going to take 2 or 2.5 hours for you to do. But if it's the risk to the patient is very low under local anesthesia. So there's no real cutoff age. As far as the younger end, my experience in doing AV fistulas does not extend into the pediatric age group, but I know they are done. And probably the youngest person I've done it on is maybe 13 years old. I hope that answers the question.
Yeah. The only thing is, in case there's a cardiovascular disease, then one needs to be careful when the venous return is high. So that's something you have to assess the cardiac status in an elderly individual.
Correct.
Otherwise, I think, yes.
Correct. I see another question there about the maturity rates and patency rates, and we're going to come to that point in the talk. Thank you for those questions. The patient must be examined beforehand. Now, in the States, it's now a routine that the person have an ultrasound beforehand. Strictly speaking, this is helpful, but not necessary. We have found most helpful the examination immediately before the surgery. When you are examining the patient, there's a belief to use the non-dominant arm. So if the patient is right-handed, you're going to want to use the left arm. No, that's not really true. Look at point number 1. Always use the arm with the better veins if the arterial supply is the same. Follow the non-dominant arm rule only if the veins are otherwise equal on both sides. You can make an AV fistula in a paralyzed arm, a scarred arm, an arm that won't bend, but you always have to keep in mind what position will the patient have the arm in during their dialysis treatment. And that will become, the importance of that becomes apparent only as you gain experience as a fistula surgeon. But always use the arm with the better veins. Even if the patient says, oh, but I dig ditches for a living, how can I use this arm? They will be able to use their fistula arm. Examining the patient preoperatively, you need good light. You need a rubber band tourniquet. Using a glove or some other makeshift tourniquet isn't as good as a proper rubber band tourniquet. I find that's the most helpful, even better than a blood pressure cuff. Letting the arm hang down will make the veins more apparent. Putting it up on a table, it is harder to see the veins. If you haven't done this experiment on yourself, if you look at the veins on the back of your hand on a tabletop at your waist or chest level, and then let it hang down at your side below the chair level, you'll see the veins become much more apparent within 30 seconds. So pulling the patient to the edge of the cart or bed and letting the arm hang down toward the floor is a good idea. You don't have to have the patient recumbent. Having them be examined in a chair is perfectly fine and maybe preferable. With the tourniquet on, they can open and close their hand several times, and gentle slaps by the examiner of the arm and the veins and rubbing with an alcohol wipe are often tricks that let a vein stand out more. Ultrasound has an adjunctive role at this time in East Africa. Ideally, you have an ultrasound to use right at the bedside, right before you take the patient into the theater. But it's not necessary, and it does not replace the physical examination of the patient. You have to make marks on the patient's arm with a surgical marking pen before you take the patient into the theater. A sonocyte is a brand name of a bedside ultrasound machine that I have seen at use in Kenya and in the States. The ultrasound becomes more and more helpful and essential, really, in the obese patient. With no ultrasound in an obese patient, you fall back on the surgical exploration to see if the veins are suitable. The ultrasound can be used to disclose unsuspected occlusions. Many patients have had many blood tests drawn, venipunctures from their antecubital veins, and they can sometimes fool even an experienced examiner where they're thrombosed, but they almost seem like they're a usable vein. So detecting a venous occlusion or an occlusion of the subclavian veins, a formal ultrasound is ideal. This Trevor is asking a question. He says he has no provision for speaking. So when you see his question in text, Dr. Okech, Dr. Yuri, please read it to me anytime, okay? You can just interrupt.
Sure.
Problem fistulas can also be helped by an evaluation with ultrasound. Failure to mature, swollen arm, other problems. This is what the sonocyte looks like. And my experience with this is not great because of my age group. It came along after I did, but they can be very helpful. And the more experience you have with this, the better. I know they're being used for abdominal diagnosis now in some A&E settings in East Africa, and that's a great step forward. You need a surgical skin marker, and these can be a reusable type or a not reusable type, but in East Africa, we reuse everything, huh? You want to prep the skin in the theater with solution that will not wipe off the marker. You mark the location of the intended pulse, for example, the radial or brachial pulse, and any vein that you intend to look at, and also make a mark for your intended incision. We're going to see an example of that in a minute. If you're seeing the patient in the clinic in advance, tell the family, look at the arms, always look at both arms, and say, and tell them, strongly tell them, not to allow any venipunctures in the arm that you intend to use, that they are to save that arm for the AV fistula, which will become their lifeline. This is some of the anatomy of the cephalic vein. You won't see anywhere near this much anatomy. Ideally, you're seeing pretty much only the vein. If you see superficial nerves, you try to preserve them. This is deeper structures. Look at the picture on the left for the location of the radial artery, and look at the picture on the right for the typical location of the cephalic vein. And your job is to bring the vein down to the artery. Your job is to swing a good-sized part of the cephalic vein down to the radial artery. You won't see all these deeper structures. Check the pulse first. Go back and forth and feel the quality of the radial pulse. Some of our diabetic patients have calcified radial arteries, and with experience, you can get to know what that feels like. It feels like what the old timers used to call a pipe stem. Like that, it feels very hard. And go back and forth, right and left, feeling the radial pulses, and pick the one with the better, you want the best arterial supply and the best looking vein. Sometimes diabetic patients will completely occlude their radial artery from atherosclerotic disease, so that can't be used. If the person has lost the radial artery, it does not mean that their brachial artery cannot be used. does not mean that they will become ischemic automatically. You can't assume that. If you're deciding between two arms, knowing what the patient's blood pressure is helpful in deciding about the strength of a pulse. If you feel the radial pulse, but it's feeble, and the patient has not just gotten off the dialysis machine, that's a problem because you need a fairly strong pulse. If you rate all the radial arteries you've ever felt in terms of pulse strength to 1+, 2+, and 3+, you want to have a 3+ or at least a 2+ strength of pulse to make an AV fistula. So decide which arm has the better arterial supply before you put too much thought into the veins. If you're meeting this patient for the first time right before they go into theater, and that will happen, look at their arms before getting too involved in a talk with the patient and the family. You can make marks on their arms with their permission, and you can make marks on both sides until you make up your mind. The way I've always done it, if I'm meeting the patient right before the surgery, I'll mark on both arms, and then I'll make a circle with the marker around the one I intend to use. Examine the arms, mark the area of vein, artery, and proposed incision, and then get into a detailed explanation with the family about what you're planning to do. For this, I typically use the back of the consent form. If it's blank, I draw a picture of an end to side hookup and tell them what we're trying to do. What are we trying to do? We're trying to make that vein get big. It's going to take some time, 6 weeks to 6 months. There are risks to the surgery, but they are minor. Lloyd and Dr. Yuri, any messages you want to go to me, just interrupt me verbally.
That's okay.
This is very helpful in discussing the procedure with the patient. You want to tell your patient about possible complications. The complications can be remembered easily if you remember the word biosyn. Write that down. It stands for bleeding, infection, occlusion, swelling, and nerve injury. Biosyn. If you discuss those things as a routine, all 5 things, then you'll always say, but I always talk to you about that. And you'll never doubt yourself. You'll be happiest if you remember those 5 things. This is a picture of my wrist having been shaved, and the course of the radial artery, the location of the pulse, and my cephalic vein has been marked. Now we mark the proposed incision. I use a series of dots going across there, and there are a variety of incisions that you can use. Here again, if you make a mistake, you can use an alcohol wipe and it will remove the surgical skin marker. My preferred incision is shown on the left. On the right are alternates you can use. Lines number 1, those 2 parallel lines, is what I started out using and what I was taught to use. But I quickly learned that the incision on the left gave the best results. You can also use incision number 2, a single incision. Which incision you choose, they can work almost equally well, but in case of a skin dehiscence, my experience is that the incision on the left is the safest. Skin incisions are very unusual in this kind of surgery. Okay, we talked about the word biosyn. Bleeding or infection are possible with any surgery. So hopefully you're saying that to the patient before any kind of surgery. The patient and their family must know that the fistula might not work. At least 10% of these never work. That's a good thing to say. How you're going to introduce these issues to the patient and the family has to do with your personality. Having another surgery someday is a real possibility for any dialysis patient. This is something that they should know. A little swelling after the surgery is expected. A lot is unusual, but it can occur, and we'll talk about that. Nerve injuries are unusual. For a wrist fistula, the commonest nerve injury causes a numb patch because of an injured sensory nerve between the wrist and the base of the thumb, in the web between the thumb and the index finger. If you're making a fistula to the brachial artery, ischemia, it becomes a problem, but it's best to discuss that as a type of nerve injury causing hand weakness or fingertip pain or numbness. These virtually never occur when the fistula is made at the wrist, but they can occur more commonly at the antecubital level, and this we'll come back to. Next, a 10% primary failure rate is optimistic and represents the very best of series. Just how you communicate this is up to you. Occlusion rates are actually much higher, and in 2011, the Mayo Clinic had a 37% primary occlusion rate in the fistula first era. So that's a very famous clinic that has very experienced physicians, and yet one in three of their failures, 1 in 3 of their fistulas are failing. Pretty amazingly, the original series of Apple in 1966 had only 2 of 14 occlude by the time they published their paper. An IV start is done in the opposite arm or hand once you know which arm you're going to be operated on. You may need that for intraoperative medicines, but most commonly for intraoperative heparin. In the fistula camps in the past, we have also given intravenous antibiotics. This is not done in the States for AV fistulas, but it is done for prosthetic grafts. However, because sterilization techniques may not be quite optimal in East Africa, you have to use your judgment in whether the patient should have a gram of intravenous cephalosporin before the surgery. Dr. LloydVincent does recommend this, and we have been doing it in the prior camps. You need a suitable table to operate on. A little arm board that's used to support an IV arm is generally not enough. 2 of those side by side could be used, but you're putting yourself at a disadvantage. Ideally is a table, small table with wheels that can be wheeled up to the side of the theater table, and that you can sit, that 2 people can sit across from each other, have room for some instruments to be placed down, and for their knees to get under. It should not have a shelf underneath it, or it will come in the way of your ankles and knees. The arm is prepped with the skin prep from the wrist to the upper arm for wrist procedure, and from the wrist to the axilla for an upper arm procedure. Make sure that the markings don't come off during the prep. Betadine or povidone iodine works very well for this, whereas Hibiclens or alcohol-containing scrubs often remove the marks. If the marks come off with the prep, stop, take the arm down, and remark it with the tourniquet again. Take a time out to make sure you're going to operate on the correct patient, on the correct side, and match up the consent form with the patient at that time. The patient should have an arm bracelet on to identify them. And my favorite needle is an 1.5-inch 25 gauge needle to give the local anesthesia. Make sure you don't put the needle through the vein as you're administering that along the line of the proposed incision. Use a 15 blade to make your incision. The vein may be closer than you think, and cautery or diathermy, if it's available, can be used, but remember that veins are very prone to spasm, and the vein is delicate and will react to electrocautery used nearby. In our last AV fistula camp, we did not use diathermy at all. We tried to use what they had on the first patient. It didn't work out. The sterility of it was very questionable, and we gave it up for the rest of the camp, and we did just fine. That's the first time If you would have asked me a year ago, I would have said, oh yes, you've got to have cautery, but you don't. You don't have to have cautery. So basically the steps are to expose the artery and vein using the Adson forceps. Be very gentle with the vein. Don't pinch it. Try and handle it with a rubber band or vessel loop. And even tiny vein and artery branches must be tied. 4-0 silk is an ideal. 4-0 Vicryl works fine. The use of topical papaverine, drip, drip, drip on the vein as you're dissecting it, does wonders. It improves patency rates, and it improves doability rates of the AV fistula. The vein will spasm as you work on it. If you don't believe this, you'll see it yourself. But having the nurse over your shoulder put a few drops of papaverine right onto the vein will be very helpful in making fistulas. Next, using a right angle clamp, as you see in the upper picture, to pass an umbilical tape or a rubber band. In the States, we call these rubber bands vessel loops. You can sterilize rubber bands that are used for secretarial work, can be sterilized and used for this, or you can cut a band from the cuff end of a sterile glove to make such a rubber band. The rubber band slides easier and is easier on the vein than using a umbilical tape made from cloth, but it can be done both ways. When the maneuver to get behind the vein or the artery is small repeated spreads with the right angle clamp. It can be done with a hemostat, but if you have one of these tiny right angle clamps, it makes it much easier. Once you have the vessel loop around the vein, you want to have vessel loops around the artery, both distally and proximally to where you're going to make your connection. For a wrist fistula, intravenously, 3,000 units of heparin is given. We usually use 5,000 units of heparin for an antecubital or brachial level AV fistula. The vein is divided, leaving a little more length than you think you need, and the proximal end is spatulated. What does that mean? We'll see it in a picture in a minute. Repeated use of papaverine on the vein is helpful, and dilating the proximal vein with dilators is also helpful. You want to check. There are two steps to do before you open the artery. One is flushing the vein with heparinized saline. You have to make sure, this is very important, you have to make sure that the vein will accept heparinized saline. If it won't, then you can't use that for an AV fistula. You have to do something else, either quit or find another vein. The other thing you want to make sure is that the patient is heparinized before opening the artery. I'm aware that AV fistula can be made without heparin if you don't have it, but it's more difficult to do and the failure rate may be higher. Everybody has their own dissection techniques. I have found that students doing this surgery for the first time, if they minimize the size of their spreads, they will traumatize the vessels less. So small spreads and small snips, small spreads and small snips, small spreads and small snips. That's helpful. Dissecting with the cautery, not when you're actually on the vein and artery. Repeated use of papaverine, and you'll find that even the tiniest little radial artery branches will give you a problem unless you tie and divide them. The distal vein, we suture ligate. You can double tie it, but whatever suture you're going to use to close the wound, the subcutaneous suture, in our last camp, we used, you can have, for example, if you had a 3-0 or 4-0 Vicryl tie, you can use that on a needle to suture ligate the distal vein as you're dividing the vein, and then save the remnant of that suture for the closure. Next slide. When you're dissecting and looking for the artery, Always remember the artery is going to be deeper under a fascial layer. It's often sitting right under that fascia. The radial and brachial arteries are always accompanied by two delicate veins. I call these the three soldiers: vein, artery, vein. Separate the vein and artery and just put the vessel loop around the artery only if you can. If you injure the vena concomitantes while you're doing the dissection, you can safely tie that vein. But ideally, you're going to separate the veins from the artery and pass the vessel loop only around the artery. Don't damage the vein making the skin incision. Remember that. Next, look at the little bracket at the bottom of the picture. You're only going to really be seeing about that much, not all this big exposure. You can see how you want to separate those little veins from the artery. If you have rubber band or glove cuff vessel loop or commercial vessel loop, putting just a single loop around the artery and placing that loop on traction is usually enough to cause vascular control so that the artery doesn't bleed while you're trying to work on it. Double looping it may be necessary for the brachial artery, but double looping it encourages spasm and does cause some problems and can actually fracture diseased intima. So single looping is sufficient for most, double looping only when necessary. Okay, you've got the vein out and your artery out. Look at the top of the slide. What are the two things you have to do before you touch a knife to that artery to open it? Have you remembered to flush the vein? Have you remembered to heparinize the patient? Ask yourself those two things always. And then, using a number 11 scalpel, make an incision in the artery. We call this the arteriotomy. Take care that the point of the number 11 blade does not injure the back wall of the artery. Even though some books and people recommend using the number 15 blade to open the artery, I think using the tip of the number 11 blade has more control, and you puncture the artery and then bring the blade up to make your incision. You can use a very small scissor or a Westcott scissor or a pot scissor if you have such a thing. These are vascular surgery instruments to extend the arteriotomy. Don't forget those two things to do before you open the artery. 45-degree angle on the 11 blade. Enter the artery straight in. What does that mean? 45 degrees or straight in? Which one? You can do both. You hold the 11 blade, going back, you see how the blade is being held at a 45-degree angle, but you see how it's a direct 90-degree straight in to the tangent on the circumference of the vessel. In other words, you want the incision to not be angled in its sides. You want the knife to be angled 45 degrees relative to the long axis of the vessel. The appearance of a droplet of blood means that the knife has usually entered the lumen. Then you can usually get to that same place with the scissors. The scissors are much less likely to damage the back wall of the artery than the knife is. This method is not always taught, but I like to use the curved tiny scissors and you'll see this in a minute, the curved tiny scissors to remove a small ellipse of the artery wall, or ellipse. The curved Westcott eye scissors works great for that. You want a smooth border to the arteriotomy. The method shown in the lower picture, where you grab the artery and snip off a piece to make the elliptical arteriotomy, I would not advise it. Sewing to an open ellipse arteriotomy is much easier than sewing to a slit. Sewing to a slit usually requires stay sutures to pull the edges of the artery apart. There's a lot of tangling that goes on with stay sutures. Removing a small ellipse does not have a downside as far as I'm concerned. No one has studied it that I'm aware of, but the stenosis rates of the anastomosis and flow rates may be better if you remove that ellipse. I'm not sure of that. Now, you're going to be making an end-to-side anastomosis. And your teacher, your clinical teacher may have a different way to do this, or a favorite way to do this, or a way that he or she wants you to learn this. Learn it the way he or she wants you to learn it. But I'm going to show you on these slides the way that I've done it and the way it's done by many, many vascular surgeons. So this vascular surgeon strongly encourages using a single suture and making a tie at the heel. What does that mean? This is a non-tying method where you use a parachute. Some vascular surgeons favor this method, and it works very well. It has the advantage of being able to see each bite ideally, but it's prone to confuse the assistant and to cause more tangles. But just so you know, when we're talking about parachuting and anastomosis, this is what it means. Note that the heel, look at the lower part of the picture, the heel and the toe of the anastomosis. That's the vein coming in from on top, or what they call a conduit. And that acute angle with the vein, that's called the heel of the anastomosis. The tip goes toward the toe. The toe will be more distal on the extremity. The heel will be more proximal. So as you're talking to your assistant, you're going to be using the words heel and toe to refer to different parts of the anastomosis. Now look at this simple picture. What's happened here? This is what has happened through the incision. The distal vein has been tied in preparation for an end-to-side anastomosis. The vein, the open end of the vein, is normally back cut to enlarge it and to make it easier to sew. So if you have a 3mm vein, you're not going to sew just the end of that vein to a 3mm arteriotomy. You're going to want the arteriotomy to be longer than that, and you want the vein to match it. So that's called back cutting, and you're going to make that cut on the heel of the anastomosis, not on the toe. If you have a branch of significant size near where you want to make the anastomosis, that's not a disadvantage, that's actually an advantage. In this case, you tie both of the branches distally, and you're going to do a little treatment on the proximal end. But this is how it's starting to set up. In this case, if you have a branch, you'll get a larger vein hood by making the cut you see in the left lower corner of the picture. You cut from one branch to another. It's easier to say than do, but it's very doable. And then you have a larger hood. We call this a larger vein hood to go onto the anastomosis. So in this case, we're going to spatulate. Go back one more slide, please, even one more. This is called spatulating the vein. You're making it into a wider hood or spatula. And this is how you spatulate through a side branch. When I'm dissecting a vein for an AV fistula, I'm looking for that side branch because I know how much easier it makes my job. I'm always looking for easy. You want to rest your hands and forearms on the table when you're doing the surgery. Everybody has a tremor. When you're young, the tremor isn't much, and it gets more as you age. But learning to control your hands, sometimes you're resting the instrument on the fingers of the opposite hands or on the table, all done to minimize tremor. And this comes with practice. This is called, next slide, this is called the lathe rest principle. It's what a woodworker uses. See his cutting tool? As the lathe is spinning, he's making a table leg. He's resting the tool on something to control his movements of the blade precisely. Here's a comparison of you with your your fine scissors or Castroviejo needle holder, how you're resting it on your other hand, just the same way the lathe worker is resting his instrument. Now this is how you do the anastomosis. The heel is on the right, the toe is on the left in this case. Ideally, you have special suture to do this, 7-0 proline or 7-0 polypropylene with 2 needles is the ideal suture for this. The ideal length for this suture is 24 inches. You have to use what you have, but I'm not advocating for interrupted sutures. I'm advocating for a continuous suture technique with a single knot. And here's how you do it. You go inside out on the artery and you go inside out on the artery and inside out on the vein to start. After that point, you go inside out on the artery and outside in on the vein. If you have a suture that has only 1 needle, then go inside out on the artery. It's better than memorizing these things. It's better to remember what you're actually doing. The intima of the artery can separate. And if you go outside in, if the artery is diseased, you could knock off pieces of calcified intima sewing an artery. So try to go inside out on an artery whenever you're sewing it. The vein can be done either way. That's the easiest way to remember it. This is the next step. You tie that knot you tie that suture you just placed, leaving unequal lengths. Aim for 1/3 length and 2/3 length of your entire suture length. 24-inch suture full on the package, that's the best. 30-inch suture, it gets a little more difficult, but very doable. And that's what we've used at all the fistula camps. 36-inch suture, it gets easier to tangle yourself up and it becomes more difficult, but it can be done with any of these. So now you've tied the heel to the heel. Now what's your next move? Look very carefully at this picture. You've got the heel tied down to the heel with a single knot. Take the longer suture and pass it behind the vein. You're not sewing anything. You're just passing the empty needle behind the vein. And now, as is shown in the picture, the vein and suture, the longer one, emerges from the other side of the vein. You're just passing the long end behind the vein. That's all. And then, using that same needle, the longer suture needle, go outside in on the vein at point number 1 and inside out on the artery, point number 2. So take a good look at this. There's 2 steps here. You've already tied it. Pass it behind the vein and then go outside in on the vein at point number 1 and inside out on the artery, point number 2. And then you just continue that way. Outside in on the vein, inside out on the artery, moving in the direction of the arrow. You have to have your assistant keep traction on the string as you're sewing on the polypropylene in order to get good hemostasis at your anastomosis. The string that you're not using, the one on the right, the shorter length, should be kept out of the way with a mosquito clamp, a little hemostat that has rubber tips on it. We're going to see that in a minute. You never want to clamp polypropylene suture with a metal instrument. You don't want to pick it up with metal forceps, and you don't want to clamp it with a hemostat unless the hemostat has rubber coverings on it. This shows an example of what the way you can clamp the fine suture. IV tubing can be used for that, but it won't sterilize well, but it could be used. Whatever you have that's sterile and tiny to make rubber jaws out of. You can do it from a very fine rubber catheter if you have that. There are commercially available tips for this too. In our camps, we've used tubing that's heat sterilizable from the kitchen and cooking industry to make these tips. But any way you can come up with rubber tips is the best thing. If you clamp it with a hemostat, the fine proline can fracture, and it may not fracture while you're looking at it. It may fracture later that night. When you're performing the AV anastomosis, sometimes you take separate bites on the artery and vein. Sometimes you go through them in one push together, and sometimes you go through them vein, then artery, but you see the vein passing between the two. So we call that separate bites. When you're talking to a student, we're referring to separate bites, or blasting through both, or a visual blast. Take a visual blast means go through both of them, but I want to see it going through. And any of these three are appropriate depending on the circumstance. Now, we go back to our little picture here. We've come around the toe of the anastomosis. It's very important at the toe of the anastomosis, as you're coming around the turn, not to take bites that are too large. Make sure the tip of the toe of the vein lines up with the corner of the elliptical arteriotomy. It's not rocket science, guys, it's plumbing. Continue this suture outside in on the vein, inside out on the artery, until you're 1/3 of the way down the front side of the anastomosis. Now, tag the suture you're sewing with. What does that mean? You clamp it with the rubber shod hemostat. Switch to the other needle, the one that's at the knot at the heel. And starting at the heel, sew 1/3 of the way up the front side of the anastomosis. When you're doing this, you have to make sure you're not catching the back wall. But if you follow these points, it'll go pretty easily. Now you've got 1/3 of the front row still open, and you use that to flush the vein and flush the artery. Passing a 1.5 millimeter dilator proximally and distally in the artery, while not absolutely necessary, allows blood to flow, and especially if you've harmed the artery with the vessel loop traction, it will help to settle that area down and dilate it up. Remember, don't catch the back wall while you're showing the front row, and the first knot is there on the right, and the finish knot is there in the middle of the front. Before you finish that last third, you flush the vein with heparinized saline and sew up the final 1/3 and tie the knot. After you finish the anastomosis, you relax the clamps or the vessel loops, and that initiates the flow through the AV fistula. If you feel the hood of the vein at the anastomosis with your finger, you may feel a thrill. A thrill is a buzzing sensation. If you have a big artery and a big vein and you sew them together, you're going to feel a thrill right away. Smaller ones, it's harder. You may not feel the thrill for the first minute or two, but then as the vein relaxes and gets used to this higher pressure blood flow rate and pressure, it will develop a thrill. The thrill is a vibration of the vein wall. A bruit is a noise heard with a stethoscope or an ear. A thrill is a feeling of vibration. If you have a vein to make a fistula with that accepts a 3 millimeter dilator, has a very good chance to make a fistula. 2.5 millimeters is in between. It may work or it may not work, but a 2 millimeter diameter vein will almost certainly fail. Some well-working AV fistulas have no thrill and never develop one. They just have a bruit. Now, at this stage of the game, you want to try to make sure that the fistula is working before you close. If you feel a thrill, it's working. You don't have to do anything more. You just dry things up and close. Using Surgicel, which is a topical oxidized cellulose piece, is not necessary. It's a luxury. and it's helpful sometimes, but it's expensive and not readily obtainable in some hospitals. Surgicel, if you do have it and do use it, can be used, and can be, a small piece of it can be left in the incision wherever you're having trouble getting hemostasis. Never close the incision if you're still oozing. Just wait. Close subcutaneous and skin loosely. If you have small staples, these can be used, but most of the time you'll be using subcutaneous sutures and skin. Closing the subcutaneous too tightly can occlude the AV fistula. So you want to keep checking that it's working. I'll show you how to listen for the bruit. Before we get to that, the steps are exactly the same to make a fistula at the antecubital level. This is a muscular individual with readily prominent veins to show us where the basilic vein is and where the cephalic vein is. The cephalic vein is what you want to use for an AV fistula at the antecubital level. The basilic vein is a special vein. The trouble is it goes subfascially about 1/3 of the way up the arm. So even though if you connected a basilic vein to the brachial artery, it would make a working AV fistula, it would likely not be usable without a special technique called transposition that we'll talk about in the second hour if we do that part. But the cephalic vein on the lateral, anterolateral aspect of the arm is what you're after. The incision to make an AV fistula at the antecubital level is your choice, and the various dotted lines show incisions that people have used, but my favorite incision is the curved line that you see in the left-hand picture, the curved white line. The curved dotted line I've never used. I've used these other incisions sometimes, but by far and away, the curved white line is what I use. I see a question has come in, Dr. Yuri.
Yeah, I think the question is how often do we see a fistula rupturing from Dr. Sampson?
A fistula rupturing. Fistula rupturing is not common, and it's usually an old fistula that will do that. More commonly is people who have bleeding at a recent puncture site, but when a fistula gets big and sometimes the fistula develops aneurysms in it, these can rupture. What you want to look for there is if a fistula develops an aneurysm, the skin becomes thin over the aneurysm. It's what I call the thin skin sign before it ruptures. And a ruptured AV fistula can be fatal. I've seen that once, possibly twice, but most of the time it can be repaired, or if you don't know what else to do, you can tie the vein above and below the rupture site. If an AV fistula ever ruptures, telling over the phone the nurse to immediately put a blood pressure cuff on above the fistula and inflate it is the immediate first aid maneuver until you get there. But this is not something to be too afraid of. It happens in very mature or older AV fistulas and can always be managed. Since this person is being observed 2 or 3 times a week at their dialysis center, it's rarely a problem. You can address this problem when the nurse brings your attention to a growing aneurysm. I hope that answers the question. It's a good question. Going back to using the curved white line, that will get you the best exposure, in my experience, of the brachial artery and cephalic vein. This just shows us the usual location. But you'll remember from anatomy class the bicipital aponeurosis, which is hiding the brachial artery. This can be divided. Sometimes it's quite stout fascia, and sometimes it's extremely thin. It can always be divided and does not have to be repaired. You're not dividing the tendon of the biceps. You're just dividing its aponeurotic extension that is not necessary. So you see how the cephalic vein is in the subcutaneous level, and the brachial artery will be at the subfascial level. So you'll always have to divide fascia to find the brachial artery. When you're dissecting for any artery, feeling for the pulse repeatedly is a very valuable sign to keep your dissection on track. If you look closely at the right-hand picture, you'll see the tiny little veins accompanying the brachial artery. Now, it is okay to use part of the median antecubital vein, that's the crossbar of the H, to reach the artery. That's fine, as long as it accepts heparinized saline, no problem. Making the brachial artery arteriotomy too large is a problem. 6 millimeters long is probably the ideal size, but it will vary in individuals. And making a brachial artery arteriotomy longer than 6 millimeters is not necessary and can risk ischemia of the person's fingers. Some females have a very small brachial artery and may be more prone to a steal, S-T-E-A-L. A hemodynamic steal means not enough blood going to the fingers because it's too much is going through the fistula. So if you have a very small brachial artery in a small female, you may have to make your arteriotomy as small as 4 millimeters in some cases. Do the anastomosis with the elbow completely extended. Otherwise, there may be tension. So some helpful nurse or assistant may want to put a little pillow or pad or folded cloth under the hand to relax it. Don't be fooled. You have to do this with the arm completely extended. Otherwise, there may be tension on the anastomosis, or if the person straightens their arm, it could even tear the anastomosis apart. In the camps in East Africa, we have splinted antecubital level fistulas in full extension overnight. And we remove the splint the next morning. In the States, if the person was going home the same day, I would instruct them about taking off a Velcro splint the next morning. But in the States, in the African camps, when we've done this, we've splinted them in plaster overnight. Your teacher, your clinical teacher, who's going to be showing you this in the theater, may not go along with this. Many doctors do not splint them overnight. I think it's safer, but I'm just trying to prevent accidents. Occasionally, during your dissection, you could see what looks like dual brachial arteries. This is usually due to a high takeoff of the radial or ulnar artery. As you know, that bifurcation usually happens about 3 centimeters distal to the antecubital crease, but it can happen proximal to the antecubital crease. In some individuals, that's not uncommon. And generally, you use the larger one of the two for the anastomosis. What if you're having problems? What if you've torn off a small arterial branch during the dissection? No problem. If there's enough of a stump to tie, clamp it with a mosquito hemostat and tie it. If there is no stump, it'll either stop on its own, or if necessary, you use a single suture of 7-O-proline to stop it. What if you finish the operation and take the clamps and vessel loops off and something is bleeding? If there's a bleeding point, if it's tiny, it'll usually stop with light gauze pressure. If it's a persistently bleeding, then place an interrupted suture of 7-O-proline. What about if the entire anastomosis is bleeding? That means that you haven't had your assistant maintain proper traction on the suture, keeping it taut. Sometimes you have to take down the whole anastomosis to fix this. Sometimes you may be able to snug it up by retying it, depending on how much suture is available. But it has to be snugged up or redone. What about oozing from the anastomosis or soft tissue? You can't fix oozing with sutures. You can by weighting. So light gauze pressure and weighting may take some time. If you have protamine sulfate can be used to reverse the heparin. If there's particular oozing, you can use topical Surgicel, thrombin, or gel foam if you have these adjuncts available. So the most common thing to do is wait. The second most common thing to do is give a small dose of protamine sulfate. What do you do if there's no thrill in the hood of the vein? If you have an intraoperative Doppler, you can listen and figure out if it's working. But I'll show you in another picture how to stay sterile while listening over the incision with a non-sterile stethoscope. I'll show you that in a minute. If there is no bruit with a stethoscope, then it's not working and you have to fix something. What about you open the artery up to make the anastomosis? I'm sorry, before opening the artery, you find that the vein will not accept heparinized saline. That means the vein is obstructed. You might have been fooled on your exam. Do not open that artery. Use a different vein or move proximally to a larger vein. These are situations in the States where we sometimes did an AV graft where a fistula was planned, but that would usually be untenable in East Africa. So there may have to be times when you would back out after exploring the vein and tell the family that the vein wasn't suitable and we can't make a fistula. In that particular circumstance, which we did run into on our last AV fistula camp, I would never go to the opposite arm on the same day. Some surgeons have done that or might teach that, but it's against my better judgment. The most common way to move proximally is the following. You're trying to do an AV fistula at the wrist. You see that the vein is too small to use or it's occluded. Then you close the incision and make an incision at the antecubital level. And you can tell the family in advance that that's a 1 in 10 or 1 in 20 possibility. What about if the vein accepts heparinized saline flushing, but it's relatively high resistance when you try to flush it in with a syringe? I would go ahead and make the fistula at that point. Passing a dilator, if you have it, can be used to lower that resistance by gently dilating a stenosis, but this has risk to it of perforating the vein. If you're trying to dilate a stenosis in a vein in an area where you cannot see, it's even more risky, and you have to be careful and not perforate the vein there. If you do perforate the vein and don't realize it, when you initiate flow in that AV fistula, you will get a remote hematoma, and you better be aware of that when you initiate the flow. I'm not trying to scare you, but it's best to proceed with a stenotic vein in my experience. What do you do when the patient returns to the clinic and the fistula is working when they left the hospital, but now there's no bruit? Remember that you explain the biosyn complications to the patient and their family. You tell them that they're the 1 in 10 patient in whom it didn't work, and you have to plan for a new AV fistula. Removing the clot from a native vein AV fistula is usually not going to work to get it going unless you're still in the theater. What do you do if the patient is returned to the clinic for their suture removal and that they have significant oozing and serous drainage from the wound? Most commonly, the person has been overusing the arm. They must rest and elevate the arm. No use of a sling, daily dressing change. Have them come back in 2 weeks. Don't take the sutures out that day. What if you What if the person's wound is swollen? Don't remove the sutures. Continue to rest and elevate the limb. What about this rest and elevation? What I tell people after an arm AV fistula is the first night after the surgery, they can't use the arm for anything. It's got to be rested on a pillow and elevated. Starting the next morning, they can use the arm, but only for eating and drinking, nothing else. They can't button their clothes. They can't zip their zipper. They can't open a doorknob, just eating and drinking. And to keep the arm rested and elevated until they come in for their check in 2 weeks or 10 days. 10 days to 14 days is the ideal time. What about if they come to the clinic and the whole limb is swollen? The side with the AV fistula is swollen, the hand is swollen, all the way up to the axilla. This is an undetected stenosis of the subclavian vein, probably from a previous dialysis catheter. If you have interventional radiology available, they may be able to dilate that stenosis. If it is disabling, and it can become disabling, your last resort is to ligate the AV fistula. If it's very mild, it can be managed with ACE wraps or a compression sleeve. What about if you heard the bruit in the operating room, but is absent on arrival to the recovery room? Remove the dressing. That's usually the problem. Somebody put the dressing on too tight. Check the patient's blood pressure. Is their blood pressure good enough to support a AV fistula, or have they dropped their blood pressure for some reason? After arrival in the recovery room and you hear the bruit, but now they're ready to go and you can't hear it. Those people, I would, the operating room has already been taken down. I would check with listening only through one gauze pad over the wound that you, and I would send them home and come back for another day. Some of them would return to the clinic with an audible bruit. If not, they need a new AV fistula. This is your kit to check for AV fistula. 1 pack of sterile gauze pads, 2 of them, and an inexpensive type of stethoscope. In the theater, the wound is closed. If you can't feel a thrill, close the wound, including the skin. The OR team maintains sterility, except for the surgeon, who takes off his or her gloves, opens the gauze packet, and lays 1 sterile gauze directly on the wound, touching only the corner of the gauze. Then laying the bare stethoscope right over that gauze, they'll usually be able to hear the bruit. Then the surgeon removes the stethoscope, removes the gauze, and scrubs back in to close, to help them dress. Usually, if you hear the bruit, the team puts the bandage back, the team applies the bandage, and then you listen again. If no bruit is heard at this step, then the surgeon scrubs back in because you have to reopen the wound and try to get this thing going. If you were able to inject heparinized saline and flush the artery properly, the fistula should usually be working. Before going home, these are the instructions you give to the patient. We've talked about these already. Keep the arm level or higher for 10 days. For the first 24 hours, do not use the arm at all. Do not use a sling. A sling does not elevate the arm. The arm is dependent in a sling. Do not use a sling. After 24 hours, the hand can be used for eating and drinking only until the sutures have been removed. Leaving the sutures in longer than you think is not harmful. Bleeding and swelling are much more common if the above advice is not strictly followed. We had one person return for oozing at our last camp. The wound looked fine the day after the surgery. They went home and started using the hand for things that they weren't supposed to, and they had to come back. They had some oozing. We changed the bandage and instructed the patient again quite firmly, stomping our feet up and down, and they got the point. Most patients ideally take aspirin, low dose aspirin, 75 or 81 milligrams daily for 2 weeks. Some practices do this, some never do this. We have arrived at doing this for 14 days to increase the patency rates of the fistula. In the States, we did this for every patient forever. After the first bandage is removed, nothing goes around the wrist, just little pieces of tape extending 1 inch or less over the gauze. You can have the patient come to the clinic with the original dressing on, but it's better if they have some pads to change it. The gauze is never folded. This is not a pressure dressing. Pressure dressings will occlude fistulas. The patient should never be allowed to have an IV or venipuncture on the arm for the fistula, either before the fistula or after it's done. Then give written instructions to the patient or very strong verbal instructions. Never wear a wristwatch or an ID bracelet on this side. Never put tape circumferentially. Never permit a blood pressure to be taken on the fistula arm as long as the fistula is working. Are you ready to try it out? I'm happy to answer any questions.
Thank you, Dr. Jerry. I think that was very, very practical. I think with even pictures of the instruments, different surgical techniques and tricks, I think that will come in handy. There were 2 questions that were put in the Q&A chat box, I think from the beginning,
Sure.
by a participant by the name Godfrey. The first question is, what is the success rate of AVF formation among diabetic patients? Second question is there any benefit or need for reversing failed AVF back to normal, or they can just be left alone?
The first question is
what is the success rate of AVF formation among diabetic patients?
The success rate is as good with diabetic patients. The success rate is good if the patient is selected properly. The main mistake with a diabetic patient is attempting to do a radial artery fistula, that is at the wrist, on a feeble pulse. So if you're saying to yourself, well, I think that pulse is strong enough, be careful, because if the pulse isn't clearly strong, then you might be better off doing it at the antecubital level. I had one partner, a very good surgeon, and he stopped doing wrist fistulas, which I think is a big mistake. So I'm not encouraging that at all. He was fooled too many times into thinking that a wrist artery was strong enough pulse. If you've all felt hundreds of people's pulses, and so you know the difference between a strong, a not so strong, and a weak radial pulse. You don't want to use a weak radial pulse. If you start going for weak radial pulses, you're going to dissect them and open those arteries and find out that you're dealing with diseased arteries. And then those fistulas will, if you can get them to work immediately, they will fail fairly soon afterwards as that disease progresses. What is the second question again? I didn't hear it clearly.
Yes, the second question is there any benefit or need for reversing a failed AVF back to normal? Or they can just be left alone? Yeah.
Okay, that's a good question. So if you have an AV fistula occlude either 1 day after the surgery or 1 year or 10 years after the surgery, do you have to reverse it? The basic answer is no. If you have a patient complaining of their fingers after an antecubital fistula, that is a person that you might have to reverse the fistula by tying it, by purposely occluding the fistula, by just putting a ligature around the vein that you work so hard on. And the person may complain of tingling in their fingers, or they may demonstrate anesthesia in their fingers, or in the worst cases, they may have motor dysfunction in the hand. This occurs primarily with antecubital level brachial fistulas. Remember, we talked about limiting the size of the arteriotomy. So, but there will be times that because of a combination of the patient's blood pressure, that you will have to reverse the fistula if the patient is having finger ischemia. And the way I made these decisions throughout my career was if the patient complained of tingling in the fingers, I would tolerate it and it would usually reverse. But if the person had demonstrable anesthesia of the fingertip, so if on any finger, if you could poke it with a needle and they could not feel it, that is a fistula I would tie. If a fistula occludes by itself, you don't have to repair the artery. You don't have to take the vein off the artery. You just leave it alone because the hood of that occluded vein acts as a vein patch on the artery, and the artery will just keep going its normal flow through its distal aspect.
Thank you. I think
Other
that makes sense.
Other questions?
Yes, there's another question on what is the intervention for patients with stenosis on the proximal portion, resulting in distal growth of AVF, aneurysm, and collateral blood vessels.
It sounds like more than one question. If a person has a proximal stenosis and the whole arm swells, if the whole arm swells, the swelling is almost always in the upper part of the upper arm or at the subclavian level. The intervention there, if you have an interventional radiologist, they can dilate that with a balloon and stent the stenosis in the subclavian vein. And that's the ideal treatment for that. If you don't have an interventional radiologist, I would generally not advise operative repair of the stenosis at the subclavian level. I would, if the whole arm is swollen, if you can, sometimes compression sleeve can control that. These are more readily available in North America than in Africa, but it's one way of controlling it. And if not, the fistula can be ligated and then the arm will return back to a non-swollen condition almost immediately. And then you have to make another fistula elsewhere or look for those possibilities. And then there was another part of the question that I didn't understand that completely. The question part about aneurysms and collaterals.
My question is about a patient with an AVF, which is already created and it was working, but noticed to have a stenosis on the proximal part of the blood vessels, which is resulting to distal growth. Instead of the vessel growing upward, it's going downward.
Okay.
And also having collateral blood vessels. And then the portion that has been cannulated, it has become it has an aneurysm, which is quite big in size, like more than 2 inches above the skin level.
Okay, thank you. This one, I would have to see, I'd have to see it.
Bye.
I would have to see it to give the best answer, but I can speak about these things in a general sort of way. You remember in the early pictures in the slides, we showed a side-to-side anastomosis. These are still being used by some doctors. If a side-to-side anastomosis is made instead of an end-to-side anastomosis, then the distal vein may develop more than the proximal vein. You want the blood to go proximally up the vein instead of distally. In the days when making side-to-side fistulas were common, something would happen called the sore thumb syndrome. And people would get big veins developing in the distal cephalic vein, and often those patients had to be taken back to the theater and have the distal vein ligated. So if that's the problem, if if someone has made a side-to-side fistula, the distal vein can be ligated. That will direct more flow to the proximal vein and solve the sore thumb problem. The problem you're describing is more complicated. If there is an aneurysm arising in a mature fistula and the aneurysm has already grown to be 2 centimeters above the level of the skin, that can be dangerous in that size group. So that needs to be developed. That needs to be addressed. And there's more than one way to address that, depending on if you have interventional radiology or not. Presuming that you don't have interventional radiology, any aneurysm, whether it's grown in, if it's in the main course of the outflow vein, or if it's in a collateral vein, one choice is always to ligate it. That may mean ligating the main outflow flow of the AV fistula, which will stop the AV fistula. But at least the patient will not rupture the aneurysm, potentially fatally. However, in the States, there's a variety of other operative treatments for this, some of which could be used. If you had a short piece of, in the old days, it was more common to simply excise the aneurysm and replace it with a short length of prosthetic graft. That can be done in East Africa without a graft by excising a piece of saphenous vein or other vein and inserting it to try to maintain patency of the AV fistula. So ligating is possible, repairing it with an interposition is possible. And the other way, which is more popular now, is that it is possible, it's a more advanced technique, but it's more possible to open the aneurysm and repair it by tailoring it down to size. So this is something that vascular surgeons would know how to do or could figure out how to do, but is usually done with blood pressure cuff inflated at the level of the axilla to a level that will stop all flow. And then the aneurysm is opened and tailored down by excising portions of it and doing a suture line and then closing the skin over that. But ask a follow-up question if you have to. Does that help?
Yes, Happy, is your question answered?
Yes, it is answered. We look for the intervention for the particular patient. Thank you so much.
Yeah, but don't let it get too much bigger. Or the other thing, by the way, enlargement of the vein is expected. The ideal thing is if the vein enlarges smoothly. So it's not getting an aneurysm in one place, but it's small in another place. The most common reason for that, listen carefully, this is called one-site-itis. This means the dialysis nurse or the patient is directing the dialysis nurse to keep poking the same place in the vein. Then the vein gets enlarged. Then the vein gets enlarged in those places as the vein loses its structural integrity from so many needle punctures and not having enough time to heal. And then it becomes an aneurysm at those places. You have to discourage that and encourage the nurse to spread out the puncture sites. They must be used all along the line of usable vein. If you keep using the place that worked the last time, because that's what the patient says, or that's where the nurse knows it's going to work, they will get an aneurysm. When you see these areas just beginning to develop, or they're small aneurysms, then you can make for the patient an elastic band to wear over that site. Even though we tell patients not to wear any bands around their arm, when the fistula is older, you can't occlude the fistula with an elastic band, or it would be almost impossible. And so wearing an elastic band made out of an ACE bandage or an elastic bandage can be done to compress the areas that are enlarged so they don't enlarge further. And then the nurse uses the area in between those bands. I don't know if that makes much sense to you, but from a practical standpoint, that's a very good way of avoiding problems.
Well answered. Thank you.
You're very welcome, Happy.
Thank you.
All right, I think as you're waiting for Dr. Valdez, there's another question on the Q&A chat box from Caro. I think the question is, what causes clots in mature AVF seen during cannulation?
Hello?
Clots during cannulation. You know, Dr. LloydVincent may want to jump in on this too, but clots during cannulation could be due to an inadequate heparinization or thrombogenicity of the patient's blood system. Clots during cannulation can also be caused by an upstream stenosis of the outflow vein. You would see, so if there's not rapid enough flow through the vein, that could be a cause. Lloyd, what do you say?
Yeah, I think what's important is the thrombogenicity of the patient. Quite often, these patients have multiple failed fistulas, and because of and you really need to evaluate them for a prothrombotic state. That would be the important thing. Sometimes maybe protein S, protein C, antitomin 3 deficiencies, and more. So that will need to be evaluated, especially if the patient has multiple thrombosis that comes on. And usually, you will see that the fistula doesn't last too long in these patients.
Right.
So yeah, that workup will have to be done. Yeah.
Right. Lloyd and I'm sure, have seen occasional patients, possibly rare patients, but occasionally we have seen where in order to maintain a patent AV fistula, it's necessary to keep the patient systemically anticoagulated. Wouldn't you say, Lloyd?
Quite often we don't have the facility to evaluate these patients. I mean, these conditions that they come with, and then we will need to have them on anticoagulation and constantly monitored. So of course now we have drugs like the Apixaban and things like that, but it's still, in despite of that, some of them can coagulate. So you need to have a close watch on these people, and quite often access is a big problem because they may not have veins left. So that is a big challenge, and then you may have to continue into catheters of the large vessels. And again, there too, you could have problems because you have thrombosis of the subclavian, of the central veins. And that is again a challenge that can come on. So yeah, some patients really go on and on and on. It's very difficult sometimes. Yeah, thank you.
There is a part 2 to this talk that has some more advanced topics. It's a much smaller, or I should say shorter talk. It's about a half hour long, and Lloyd will decide in the future if we should have that addressed at another time.
Yeah, sure, Dr. Jerry. That definitely, yes. We'll fix another time, sometime during the week.
I have the question. I want to know about your experience in the superficialization and transposition of the basilic vein. I want to talk. Okay, please.
Yes. Well, I covered that in the second hour, and Dr. Valdez's question for the others, he wants to know about the experience with superficialization of the basilic vein. Remember that the basilic vein is the vein that runs up the inside of the upper arm, and we see it by examining the antecubital fossa. It's often the largest vein that you see on a tourniquet exam, but that vein is not usually suitable for an AV fistula because it runs under the fascia. So even though you make the connection and the connection works, the vein never enlarges to where the nurse can put a needle in it. However, years ago, a method was developed, and there are several different variations of this, but this is covered in the second talk. It is possible to make an incision on that arm, on the upper part of the arm, and the way I've done many of these, and we had a very good experience. We published a small series of them. The vein is freed up for the whole length of the upper arm. It is detached from the other veins at the antecubital level. It is tunneled under the skin superficially at the axillary level, and an anastomosis made at the antecubital level. What this means is moving the vein to a subcutaneous position throughout its length. We had great success with this. Now it has evolved into certain doctors doing the operation in a one-step method or a two-step method. I always favored the one-step method and used a long tunneling instrument, and I had great experience with this. The doctors who do a two-step method, they make a simple end-to-side anastomosis at the antecubital level as step one. And then when the vein gets larger, maybe 6 weeks later, 2 months later, they come back, and through a variety of incisions that has been proposed, either long incisions, short incisions, they bring the vein closer to the surface. This I have not been entirely happy with, but my partners have used it, and with some success. I found the one-stage method simpler. How about you, Dr. Valdez? What have you used?
This is a good question, because sometimes the patient, we don't have the time for the superficialization. The patient need immediately start the hemodialysis. It's a very interesting question, because I like sometimes is the procedure to the same procedure, creation the fistula and superficialization the basilic vein. Sometimes the cephalic vein is occlusion. The cephalic vein. The only possibility in this art is the basilic vein.
Yes.
Okay. Thank you so much.
Yeah. The in my experience, the basilic vein transposition, we call it basilic vein transposition, and in my experience, it's a 2.5 hour operation, and it was I think the first 4 or 5 of these I did under local anesthesia, and that's pretty taxing on the patient. Doing them under general anesthesia makes the operation more predictable, and I would encourage you to do it a one-step. Dr. LloydVincent can give you my contact information. I can even email you copies of the little article that has nice pictures that were drawn by my wife to show how to do this.
Okay, thank you so much.
Thank you, Dr. Valdez.
All right, I think we have come to the end of the talk. I think it was quite insightful, very practical, and looking forward to the second talk. I think that we'll major more on I believe the either fast one-step or two-step procedure for the basilic vein, either superficialization or looking at whether it's transposition by Dr. Jerry. So thank you for that, Dr. Jerry. And I think we look forward to that second session.
Very good.
Thank you. So on behalf of Africa Healthcare Network and our panelists, thank you for making time to take us through this very insightful talk. I believe we are much better now than how we started. And I think even as the surgeons are going to do the procedures this coming weekend or this coming week, they have a few tips on how to proceed whenever they are stuck. And of course, Dr. Lloyd will reach out to the surgeons who need any help and also connect them to Dr. Jerry. So grateful for the talk, and I'll give it over to Dr. Lloyd for any closing remarks. Thank you.
Yes.
Thank you, Dr.
Thank you,
Lloyd.
Dr. Jerry, for this wonderful session. Very, very useful, practical tips, and something, a lot of experience that is compressed into 1 hour. A phenomenal amount of experience, and it will be very useful for people who are actually doing the AFist. And I think this is the whole talk is recorded, and we'll edit it and we'll put it up into YouTube in the next couple of days itself. So it is available to everyone to go through. And I think very, very useful. In today's days, even the nephrologists today in a number of countries are now doing fistulas. And I think this is a very, very useful tool to actually, the set of this video would be very, very useful to everyone actually. I will fix a time for the second session. The graphs, it is relatively shorter, half an hour, and that sometime during this week, Dr. Jerry, or anytime you are free, we will have it sometime around the same time, maybe next week or whenever you have the time. I know you're traveling. Then the coming week, after that, we could have it, no problem at all. So thank you so much for this wonderful session again, and so much of spending so much of time into East Africa, and actually Zambia is more towards Southern Africa. Thank you so much, Dr. Jerry.